Hi everyone, thanks for joining. Today we have 45 minutes, and as a reminder, one question and one follow-up. We have Dr. Brown, Dr. Huyer, and Dr. Williams here today, so I'll turn things over to Dr. Williams to start.
Well, good afternoon, and because our priority today is to give an update on our analytics and modeling, and we have Dr. Brown here from the modeling and scientific table to give an update as we promised he would today. And it's important to look at that as we've seen our cases, hospitalizations and deaths have continued to rise. So it's a critical time for our province. And so I think it's important. I'm not going to take a lot of time. I'll have some comments to make later, but I'd like to make sure we give time for Dr. Brown to come up and present the data points and some of the information there, because we want to see how, in the analytics, how is Ontario doing? How are we doing as compared to where we were the last time we got an update about 2 weeks ago? So with that, I'm going to hand things over to Dr. Brown. Welcome.
Thank you. I'm going to be referring to some slides that I think have been distributed already to the media. If you go to the second slide, the purpose of today's briefing is very simply to provide an update on the trends in the COVID-19 epidemiology and the health system indicators, and to provide an update on progress in controlling pandemic. We've got a set of key findings, if you go to the next slide, which I think are important to keep in mind. The first is that key indicators of the pandemic continue to worsen, and although the impact varies widely across regions in the province, most indicators are moving in a worsening direction across the entire province. It's important to look as we get into the modeling as well to understand that we are trying to compare ourselves to countries that hit their second wave earlier than we did, after accelerated growth or accelerating case numbers during the early fall. But as these countries have faced higher and higher rates of case growth, they have struggled to control the pandemic, and all the countries we'll be comparing ourselves to today are in lockdown. It's important to note that long-term care home resident mortality is increasing, and as community spread continues, outbreaks will increase, and as outbreaks increase, the risk of mortality in long-term care homes will continue to increase as well. And at a 5% rate of growth, which is probably a reasonable estimate of where we are right now, our case numbers will likely exceed those in several jurisdictions in Europe that are, as I said earlier on, in some form of lockdown. Under any of the scenarios that we look at, ICU occupancy will exceed 150 beds across the province. This threshold of 150 beds is an important threshold because it's that point at which we need to start cancelling planned surgeries, and we can no longer deliver the full slate of planned care right now. We're going to start to present some novel analysis today too on wastewater tracking that suggests that first might give us a leading indicator finally of progress in the pandemic, and suggests that at least some of the restrictions may have made the current surge less than it could have been. If we could go to the next slide, please. This slide shows the total new cases per 100,000 residents per week across public health units. As you can see, the highest rate here shown is 100 and, sorry, just my own problem with my eyesight here. 130, thank you, 0.5 in Peel, down to all other public health units at just over 25. This is an important sort of slide because it shows the growth across all public health units as we're looking at the growth in the pandemic. If you go to the next slide is the new cases with no epidemiological link across public health units. This slide shows a high level of cases with no epidemiological link across some public health units. It's important to keep in mind, though, that the slide is a result of several factors. The first is community spread. As community spread increases, the number of cases where it's hard to identify the source of that case increases. Second, as the level of cases gets to a certain level, it's very hard to track all of those cases. And priorities must be placed on tracking the most important of those critical cases. And finally, there's also some issues of changing systems here. This doesn't mean that case and contact tracing isn't important. It's an important part of pandemic control, but there are some reasons why this number is high. If you go to the next slide, this slide shows COVID-19 testing percent positivity across public health units again. It's important to emphasize the public health units aren't doing the testing, but this does give you, again, a reasonable picture of how performance on the pandemic varies across public health units. And as you can see, in a number of units, we've got case rates rising. We have percent positivity rising as well. And that gives you an idea that the spread of the pandemic is at this point quite significant. Important to note that we've got high rates of positivity in a number of these communities. Even where we have distinct cities within these public health units, often the percent positivity is high in all of those cities. I think it's also important to note here that if you look at, we've called out the statistics here for a number of the individual public health units, but even when we look at those public health units where the overall case rate is lower in a relative sense, the percent positivity is now up to 1.9%, which more than doubles what we would have seen late in the summer. So significant growth here in the percent positivity. And if you go to the percent of tests processed within 2 days across public health units, you can see again significant variation between almost 90% being processed within 2 days down to just 2/3 in another public health unit. So as you can see here, given a relatively consistent volume of testing, case rates are growing substantially. The percent positivity is growing substantially, and we are starting to not have the ability to track all of our cases. In some public health units, that's quite acute, which means that we are in very clearly a second wave of the pandemic. If you go to the next slide, this slide looks at the percent positivity by age group, and this is important. In younger age groups, we see relatively little hospital use, we see relatively low health consequences. And although younger age groups are entirely capable of transmitting the disease, as long as the disease stays in younger age groups, the consequences for health and for the health system are relatively minor. However, you can see here that we've had substantial growth in the percent positivity in older age groups now, in some cases tripling or quadrupling. And this is very sort of challenging and dangerous news for the health system. If this age spillover as we've termed it in the past continues, you will see growing hospitalization rates, growing at an even faster rate, and you will see mortality climbing as well. If you turn to the next slide, and that is slide 9, this slide talks to cases in long-term care homes, both among staff and among residents, and mortality among those residents in long-term care homes. I think it's important here to note that when we made our first presentation this fall, early in October, we saw a relatively small rate or level of overall mortality. We've now tripled the mortality that we reported over that in that first briefing that took several weeks to accumulate. It's now 71 deaths in the past 7 days. And as case rates climb, you can expect mortality to climb as well. I should also note that the 10th of August, at least in the long-term care homes tracker, showed the highest number of deaths in long-term care homes since August 1st. Moving on to slide 10. Slide 10 shows what happened in jurisdictions in Europe. In this case, we're looking at France, Netherlands, the United Kingdom, and Germany as COVID case rates grew. You can see on this chart that all of these jurisdictions impose some form of significant restrictions, what's often called sort of a lockdown at some point. But given the strong case growth up until that point, it was very challenging to get control over the total case growth. Basic idea is that the later that one intervenes in the epidemic curve, the harder it is to get the case growth under control. What you can see if you go on to the next slide is where Ontario would sit compared to these jurisdictions. This is a bit of a challenging slide to look at because what we have done is taken the growth in cases in Ontario, and our model sort of kind of predicted us to right where we are today, about 10 cases per every 100,000 people. And then it looks from that point to see what would happen if we grew at 3%, or if we grew similar to those other countries I've just mentioned at this point in terms of total number of cases. What's important to note here is that at a 3% rate of growth, we actually outstrip the French growth before the end of December. France is right now in a lockdown. although this is talking about an earlier stage of the growth of the disease or the growth of the epidemic or pandemic in France in the second wave, it gives us an idea where we are relatively to these other jurisdictions. When we built these models a few days ago, 3% was a reasonable way of capturing the 7-day or average 7-day growth in total number of cases. 7-day growth is actually probably closer to about 4% right now, so it's climbing up. This suggests that if we do not take any action, you will find yourself, or if there's not efforts to control the pandemic, we will be higher than France by before the end of December. If you go to the next slide, this is projections at a 5% rate of growth. And it's important to kind of emphasize, although this is only a few percentage points difference, this daily growth rate adds up very, very quickly. And so under the 5% growth rate, before the end of December, we're between 6,000 and 7,000 cases a day, compared to the 3% where we would be between about 3,000 and 4,000 cases per day. So it's important to note that even small changes in the rate of growth result in large changes in the number of cases. The 3-day rate of growth a few days ago was about 5%. It's now 6%. And so if the last few days is a reasonable point of extrapolation, it's fair to say that the 5% is a current or maybe even a slightly optimistic scenario. What you'll see in this chart, though, is that by the using the 5% rate of growth, we actually have more cases than France, the US, or the Netherlands at this point. And of course, France, the US, or UK or Germany at this point, and we're getting close to where the Netherlands are. It's always hard to compare countries. There's different population densities, there's different sets of public health interventions, there's different levels of adherence to the public health recommendations. But in this situation, you see a very, very significant growth of the pandemic. If you go to the next slide, which is slide 13, and these slides are available on our website and I think available on the government website as well, you will see that COVID-19 hospitalizations continue to rise. It is about a 61% increase now over the past 3 weeks and about a 167% increase over the past 6 weeks. Now, it is still a relatively low number of hospitalizations compared to the total number of hospital beds in this province, but it's important to keep in mind as well that our hospitals run very close to capacity at all times, and particularly given the access to care deficit that built up in the first wave, this makes it very challenging to actually get caught up and provide people with the care that they need. Going on to the next slide. It's important to emphasize that while cases are growing dramatically and hospitalizations are now growing substantially as well, there are some changes in how COVID is being treated, which are positive and which should create extra capacity within our system. Particularly on this, you can see that the length of stay in this slide, which is slide 14, the length of stay for patients with COVID-19 has declined, particularly for those patients who are receiving ventilation in the intensive care unit, mechanical ventilation in the intensive care unit. And this is important because you see a substantial decrease in the length of time they're staying there, which should create capacity. However, looking at the case growth that is projected and actually is right now kind of currently tracking exactly where we are, the ICU occupancy under any scenario of the modeling will exceed 150 beds before 2 or 3 weeks are out. And you'll actually see in any scenario, really before 3 weeks have finished, that first threshold reached at which we need to reduce access to care. This is obviously an important threshold. Important to note that before the end of December, though, within about 6 weeks, almost all of our scenarios take us well over 200 ICU beds being occupied, and in the worst case scenarios, we get up close to 450 ICU beds occupied with COVID-19 patients. At this point, there are significant limitations on the health system's ability to react to additional patient needs. There's significant limitations on the access to care and significant challenges in getting people treated when they have health emergencies. If you go to the next slide, this slide shows the effect of the first wave and now the growing effect of the second wave of COVID-19 cases on access to care. If you look at the dark blue shading here, that's the medium blue shading, that is the level of COVID-19 cases in the province. You can see in the first wave there was a significant limitation of hospital care, significant limitation of emergency department use, significant limitation or reduction in access to diagnostic imaging. That started to return with a gradual reopening of hospitals back up to what were 2019 levels. But then again, during the second wave, you can see this starting to come down again, which will add to the deficit of care. However, the challenges on care, on outcomes, are not just limited to what happens in ICUs or what happens in long-term care homes. It's clear that the pandemic will have and is having a substantial impact on mental health and mental health care. Overdose deaths have been a serious public health issue for a decade. We had an average of 34 deaths per week due to overdose in the 3.5 months before the pandemic. This increased to 46 deaths per week in the first 3.5 months of the pandemic, so almost a 40% increase. Although this is related to the onset of the pandemic, we should not expect this to necessarily improve immediately with the conclusion of the pandemic. Although the majority of community and mental health and addiction services have tried to remain open, often with changes or modifications, some access to services has been severely limited, particularly access to residential treatment services. There will be, or we should expect to see also, long-term consequences in terms of health and access to services because of this delay in treatment. It's going to be important to continue to monitor the impact of the pandemic on mental health and addictions care and on mental health and addictions outcomes. Finally, going on to slide 18, I'd like to present the first of the analyses on wastewater testing. Cases, hospitalizations, ICU admissions, and deaths are all what we would call lagging indicators. It takes a while between infection and any of these items to actually show up because of waiting for onset of symptoms to trigger testing, or the receipt of a positive test from a contact that then leads to further testing. Wastewater testing is a way of getting a sense of where the disease is heading. It's perhaps an early barometer. You can see on this slide, which is slide 18, the results for Ottawa. Sampling at the wastewater plants helps us identify when the RNA from the virus starts to spike within the wastewater. You can see that it starts to grow very, very strongly up until about just after the period where the new restrictions are put in place, and then begins to come down, very much in line with what we've seen with the Ottawa case data. This is likely, the initial sort of reduction is likely due to restrictions placed in Ottawa, or the first set of restrictions in Ottawa or limitations mid-September, and then the continuation likely related to the restrictions that came in on October 10th. If you look on slide 19, this is the slide for Peel. Again, you can see this rapid growth, and then really a little bit of a plateau before what we expect will be further growth, reflecting the continued growth of cases in Peel, saying that although restrictions may have had a modifying impact on the total rate of growth, they've not been sufficient to control it. Then just concluding again on slide 20, which are the key findings to reiterate. The key indicators of the pandemic continue to worsen across the province. The impact of these indicators and the level of these indicators does vary across public health units, but it continues to worsen across the province overall. Other countries that have allowed substantial case growth have now found it very hard to turn that curve and arrest that case growth. Long-term care home cases are growing among both residents and staff, and resident mortality is growing substantially. The outbreaks continue to account for about 10% of cases, although we know from some recent research now just published in the journal Nature that indoor environments where health protection is difficult, those are places where there's limited ventilation, where there's close contact, where it's difficult to maintain health protection, really do account for the majority of cases. At a 5% rate of growth, which might be considered either somewhere between current and an optimistic scenario, our case numbers will likely exceed several jurisdictions in Europe that are now in lockdown. We're starting to mount the same curve that they did earlier on this fall. ICU occupancy, we expect will exceed the 150-bed threshold under any scenario within 2 weeks, and it will exceed 400 beds under the worst-case scenarios within about 6 weeks. It's important to note that what we see today will likely actually continue along for a while, even with new restrictions, because of the way that infections turn into symptoms, turn into hospitalizations, and turn into or time delay, and then turn into intensive care unit admissions. The wastewater tracking suggests that the restrictions on October 10th might have actually helped delay or moderate some of the growth that we were seeing, but they are not sufficient necessarily in and of themselves in these jurisdictions. I should note that our modeling does not take into account the most recent set of restrictions that were announced in Peel, which we expect will have some impact on the case numbers. Thank you. Dr. Huyer?
Thank you, Dr. Brown and Dr. Williams. Good afternoon, everybody. Just wanted to give a quick update about outbreaks and a little bit of context around building off of what Dr. Brown said as well. Today we're reporting 29 new outbreaks, and if you look at the proportionality, it breaks down to about 18 in the vulnerable sector and in the school sector. 6 are in the public-facing sector, including retail and other settings where the public would attend, and 5 in workplaces. We've also recognized a 57% increase in outbreaks over the past week, with 168 and 632 over the past 30 days. We now see outbreaks stretching across 22 of the 34 public health units, and we see a range of outbreaks. Initially, it was in the most vulnerable sector, in the long-term care homes and in schools. We're now seeing it in a variety of different sectors, as I've described before. As Dr. Brown pointed out, it's important to remember that while outbreaks are something that's identifiable, it's 10% of the cases. And it's really a proxy or an example or a view into what the community spread is. And it speaks specifically to the importance of recognizing the importance of, or the transmission within social settings. Those social settings may be within a home setting, it may be within gatherings that people get together in, or it may be a social setting outside of the home location. But it's people bringing the infection into that social setting, and then that may be where the outbreak is identified because somebody brought it in and then shared it, or the transmission occurred with others. And some key things that we've learned from that and from observations from the public health units are people come to work with symptoms. The screening at work may have not been followed or identified the person. The IPAC, or the personal protective equipment, that was not necessarily being used in the most effective way. And then there's gatherings during and after work. So all of those things contribute to the sharing and the transmission. An important key point is to recognize, and Dr. Brown touched on this, but just to elaborate a little bit further, with the increased number of cases, it's again associated with an increased number of contacts, and both of those things, the increased number of cases, increased number of contacts, make it very challenging to be able to identify the source, because trying to understand the complexities of case management with many people that you intersect with makes it very difficult to sort backwards and try to figure out where things where the transmission actually occurred, and then also challenging to be able to contact and connect with all of those who might have been in contact in a high-risk situation, which is important to stop the spread. So all of these things are crucial, and they speak to the transmission. Dr. Brown spoke to the healthcare capacity, and the case management and contact tracing speaks to the importance of the public health unit capacity as well. And finally, what we've recognized through a number of the outbreaks have been associated with specific social gatherings. Just some examples, some Halloween parties, weddings, places of worship, other social gatherings that have occurred. And all of those are important because people gather and there's a risk. Then they travel to other places of the province, and then they enter into other settings, and then the spread continues to occur through the outbreaks. At this point, I'm going to stop and pass on to Dr. Williams, who will provide some additional broader perspectives.
Well, thank you, Dr. Huyer. And As you heard from the data and the input that, as I said at the outset, this is a critical time for our province. We know how difficult these past few months have been for everyone, Ontario's communities, businesses, and families. But the challenge is that we need to get these numbers down to protect the health and safety of Ontarians and to protect our healthcare system from being overwhelmed, especially as we enter respiratory virus season and flu season. As I said before, this challenge is not insurmountable, but it's going to be difficult and take everyone and each person to do their part to undertake this task. We have flattened the curve before. As I said, often we can do it again. Ontarians have continued to demonstrate their willingness to follow the directives, but we know people are getting tired. And they're tired of not seeing friends and family, and tired of not being able to celebrate life's milestones and other celebratory events. And after months of dealing with COVID-19, it's understandable that people do want to get together. But these gatherings have meant that people are having too much contact with others, and as a result are being exposed and increasing the transmission, as Dr. Brown has alluded to, such that the percent positivity is going up even more drastically over the last while. Several of our health units are managing the cases. As Dr. Huyer said, there are some large gatherings still occurring where people have not followed the directions. And then we have outbreaks related to that. And as Dr. Huyer said, that only represents a portion of the cases that are attached to those. And often when we see and we look at our data as these numbers increase over a certain amount, we start to see the case contact management sliding. And we hear interviews with people at that time. They say, well, it's shifted because we're asking people of what their contacts were. But then after a certain while, they say, well, the 4 or 5 parties at different people's houses I was in the week before, and 2 since I became sick, I can't remember exactly who was at them. That means you're dealing with a large number of contacts, and one that should not be occurring. And when that occurs, it makes case contact management very difficult, if not impossible. So I'm really, again, restating, starting way back with Dr. Teresa Tam, who said you had to restrict down to household members. Keep those limited. Do your social distancing, masking in public or indoor areas where you can't maintain that. Limit those areas of risk. Check your local data. See what's happening in your area. That may even limit even more how much you can be out and around. We've already asked those over at high risk or over 70 to limit their activities to only very essential needs to go out, and ask someone to get those other aspects for you, especially if you're in areas that in our framework are in high levels of percent positivity, and that you need to understand that by going out into congregate settings, you can put yourself at risk in that relationship. Hand hygiene, stay home if you're ill, and get checked out and tested when you need to, and do it in a prompt way, and adhere to all the directions by public health or by your healthcare provider as you undertake that period of time to quarantine and reduce your spread, and also to be aware of who you might have contacted in the idea of a close contact within 10 to 15 minutes without a mask, being within 6 feet, that we need to be able to know who they are so we can tell them, especially some of them may be working at high risk settings, that we should know right away and have them limit their activities until we ascertain whether they are positive or not. We need to be doing this vigilantly. We need to do it assertively. So I think the numbers are in front of us. The task is in front of us. And the solution we're aware of. As I said before, if everybody did what they're supposed to do, we can bring those numbers down. We can bring them down considerably. So I'd like to now ask questions from media. And if you could ask if you want to address it to either Dr. Huyer, Dr. Brown, or myself, that would help. If not, I'll try and assign it as best we can, and we'll try to move through the questions as best. And again, we're focusing on the modeling and the analytics today.
We'll go to the phone lines. Just a reminder, 1 question, 1 follow-up. Over to the first question, please.
Your first question comes from Jeff Gray with the Globe and Mail. Please go ahead.
Thank you. Hi, doctors. I wanted to ask Dr. Williams about, given the numbers that we're seeing here today in this grim picture and the framework that has been introduced, I wondered if you could explain a bit about why the version of the framework that was suggested by Public Health Ontario, why you ended up recommending to Cabinet a much more liberal, more loosened version of that framework, given the numbers that we're seeing today.
So the aspect of putting the framework together, there was a lot of work involving, including Public Health Ontario, was at our table with the public health measures. And what was fundamental in the idea around the framework itself is that could we, much like we did when we were opening up the province, we had looked at the idea of doing it in stages. We looked at the idea of doing it with different levels and different parts. We tried a bit of that during the opening up, and it seemed to work okay because we could see our province was wide and varied and there's different directions. So one of the key things that we did is that most of the content of the framework was agreed at by the table, including with Public Health Ontario, around the concept of having different levels. The colors were in and the colors are out and the colors are back in again. And the ideas of prevent, protect, restrict, and control, those concepts were in as well, including all the measures on each one of those levels. I think the part that you had heard from Public Health Ontario is that the actual numbers and metrics were ones that they had their input on, and we had those numbers put out. But I think the important thing we wanted to do is to say, in Ontario, can we have various parts of the province, because of our wide and varied geography, at different levels at different times? And the key things we wanted to do is to get that out to the public who are saying, we want to see what's going on, we want to see where we are, and do we understand? Most of the public understand the colors in different directions, and it gives them an optic and a visual saying, oh, we have a problem here, and we've gone now from this to this. This is a problem. The actual detail about the rates and that are all very critical, and we have many scientific groups that are weighing in now, and I think I appreciate the comment by Dr. Peter Uni, who's the scientific director of the Science Table, saying the key thing it's out is the debate and the discussion on the matter and see how it applies. But the other thing is key and important is that we look at that and we see these measures. It allows different parts of the province and different areas to say, if we take ownership of this within our community and our framework, much like you heard Dr. Lowe speak about and Dr. Davila, what can we do individually? What can we do as a family? And what can we do as a community collectively to do our part to bring those numbers down? So there is the framework concept itself, and then there are the different measures inside the framework. And then there's the aspect of using a number of different metrics that address that, and then the consultation every time with the local health unit, with the medical officer of health, because in these responses, because there's a wide and variation level, we need the medical officer of health to weigh in and say what do they feel is in their area, and where would they feel they need to work from, and what measures would they want to undertake themselves to address their unique challenges within their respective communities and jurisdictions. So there was input, and there's different things at different times, and input have and will continue as we go forward.
Follow up?
Well, yeah, so input then, I guess, are you going to revise this, given the criticism of the thresholds for the red and orange or levels that just seem so high? We just heard from Dr. Brown about the need for early intervention if we want to avoid a repeat of Europe here. Are you going to recommend ratcheting those levels down?
We're going to be asking our table to keep looking at what's happening. We have the model, a framework has not been out for a week yet, and we have to see what's going to happen with that. As Dr. Brown alluded to, and we know that it takes a while for us to see the results. We're just seeing with these rising numbers, these are all in place prior to the framework, and these numbers are rising in the presence of our modified stage 2, especially in the larger 4 units. And while we did see some effect there, we're seeing some areas that didn't work well, and we've seen some ideas from other medical officers, as in Peel and as in Toronto, saying even above and beyond that, there's other things they would like to undertake, because the challenge they're seeing and the challenge we heard right from or during the time of the modified 2 is they're saying what we're really seeing is a lot of personal behavior by individuals and people in their private settings, taking risks and setting aside the public health measures. And while the congregate settings, which had the scientific evidence we talked to before, that there is the evidence that says they are at risk, how much did they contribute and help in that? We're now getting that data back, and we're looking at that. And then the public health measures table will be looking at this all over again and saying, so now what should we do with that? How effective are these steps and these measures and those measures? Because it is a dynamic thing, as Dr. Brown alluded to. It's changing, it's moving, and we have to be nimble and adjusting to that. So input is always going to be taken in. We're always going to look at it. And if we have to make revisions, we would do so. But we want to be informed by the data, the science, and the evidence as much as possible.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi, Rob.
Hi, Doctor. just wondering, you guys are sending out some really alarming numbers here, like possibly, and quite likely, 6,500 cases a day by mid-December. But I don't hear any urgency.
Well, we're trying to sound urgent as much as we can. I thought Dr. Brown was being pretty clear about that, and those projections, as you said, are alarming. We're trying to not deal with, as always, we're saying to the public, we're dealing with data and evidence and facts here. Emotionally, those are other things there, but we want you as the public to know what does it look like and what are we projecting towards, and why is it important even more now to do what we need to do to bring it down. And we can't say in any stronger words. We've tried to say it before. We've talked to you and pleaded. We've given some information. We've done different points. And Dr. Teresa Tam has put that forward. And my fellow CMOHs from Quebec over to the west are in the same plight, trying to convince the public to say, you need to return to what we did during the first wave. You need to return to that household limitation in all sorts of settings, and you're seeing even further steps being advocated by Dr. Lowe and by Dr. Davila in their respective jurisdictions, seeking to get the importance of why you have to do this, why you have to bring this down individually, as a household, and as a community. And so it is alarming, and we want your attention on this matter. That's why we've brought the data back to you. That's why Dr. Huyer has talked about the outbreaks. And that is why we're showing you what's happening. Those with the high rates, it starts to go into other age groups. It affects the vulnerable. It starts to go into the schools. More and more cases showing up at the schools. We are fending them off as best we can. And it starts going to long-term care homes. And there's more outbreaks there. Dr. Huyer's alluded to that. So in a sense, we see that mirroring itself. Where you get large number of transmissions, the positivity goes up, the cases go up. It starts to impact into these other ones that we have tried to protect. We're trying to protect our school system, as well as our long-term care, retirement homes, congregate settings, all these high-risk places, and our healthcare system. And so this is a critical discussion right now, and we need to move ahead on.
Follow-up?
Yeah, just to follow up, I understand you want to act on the data and you want to clue people into this, but it does appear that people have clued out, so it's questionable whether telling them these numbers is going to work. At what point do you think the province is going to have to, at what threshold would you say to the Premier, we've left it to the public health units, it's not changing, we need to do something ourselves, or are you just not going to do that?
Definitely. When we were looking at that, as you saw in our framework, if you go far to the right, as you get into red and control, you go into lockdown. And we've seen most of our other European sectors, as they've tried to make progress, they went into various versions of what that is. And as I've asked our public health measures table to look at and saying, what would be the triggers that we would go into lockdown? How would we do that? What would it consist of? Is that lockdown in some areas, lockdown in other areas? Or is it lockdown with schools closed, yes or no? So we want to ask them that type of question. So the chart, the framework does show that. It moves as you go beyond that. If you can't do that, as many European countries have had to turn to, we were trying to say with all the measures we put in place, what Dr. Davila is trying to do and Dr. Lowe is trying to do, can we avert a lockdown, yes or no? And we have to ask our table and our expertise to say, if and when that should happen, what are the methods for that? What are the triggers for that? And what would it consist of? And should it be province-wide? Should it be regional? What should it consist of? These are all questions that still have to be answered. And we have to answer those fairly soon.
Next question.
Your next question comes from Randall DeLay with National Post. Go ahead, please.
Hi, question for Dr. Brown. Can restrictions effectively control the amount of growth you're predicting today?
You want to repeat the question? Did you hear it? Yeah, could you repeat the question for Dr. Brown, please?
Sure. I'm wondering if restrictions can effectively control the amount of growth you're predicting today. That what we did over the last month doesn't seem to have had a huge effect.
So based on what we're seeing in the models, if we continue on with the current level of restrictions, I would not expect to see any deviation from the current results. You'd continue to see growth.
Okay, so that's everything where it is now.
Well, you'll continue to see the growth, so it won't be a flat line. You'll continue to see growth in cases. You'll see the higher levels of ICU use probably hit. You'll see the mortality continue to climb in long-term care homes. And even with new restrictions, if they're implemented today, you'd still see growth for a little while in the cases and the mortality as it takes that time to filter through the system. But there is, I do not believe that there's a way that the cases will change without action.
Next question.
Your next question comes from Matt Bingley with Global News. Please go ahead.
Hi there, Dr. Brown. I apologize if you've already got into this, but what's the growth percent rate that we're at currently?
Last 7 days, growth rate percent's about 4%. Last 3 days, percent growth is about 6%.
Follow up.
Yeah, and sorry, I just wanted to follow up on Rob's question there. I'm just trying to hear a little bit more urgency from you on this as well, Dr. Williams. It still doesn't sound like we're hearing the same level from the Premier really sort of laying out exactly what we're seeing here. So I'm just wondering, can you just lay out in the straightest answer possible just where we're at right now?
So where we're at right now, not only based on our data and the modeling data, is that there are some parts of the province, especially if you see that most of our, like 1,000 of our 1,500 cases a day are in Toronto, Peel, and York, well over that. And so these dense urban areas, once they reach a certain level, are having great difficulty keeping it under control, bending the curve, and flatten the curve, if not bringing it down. And so those are in urgent issues that need to be addressed. And we have to ask ourselves, as you're alluding to, is the measures so far, how effective have they been? Will they be effective on a fairly aggressive and rapid basis? Are the steps and ones introduced and the guidance and recommendations from the medical officers in Toronto and Peel, are they going to be adequate enough as soon as we can ascertain, and as Dr. Brown's alluded to, and we've said many times, those results will not be imminently coming out. They will take a while to work its way through and see if they are actually making impact. So the urgency is where we're trying to address and assess the public health measures thus far. How effective have they been? How effective will they be? But in some parts of the province, things have not changed much. Many of them are in the so-called prevent level, but as Dr. Brown alluded to, they have seen an increase in positivity. And some parts in Northern Ontario, which had not seen cases for a long time, are seeing cases. People are coming in and introducing it in. So everyone has to be on their guard and watching and seeing those numbers in that. At the same time, we haven't yet seen the full impact on our hospital care system because, as they're alluded to, and that delay that will inevitably take place takes time to see. So the alarm is that, especially in our large areas, as they go over a certain rate, are the measures that they are asking and we're doing, are they going to be effective enough to bring those numbers down aggressively and assertively? And so we have to ask our experts that question, and I posed that to them on Tuesday. They're going to be looking at it again and coming back with recommendations to me where we should proceed and give advice to myself and then that to the minister and onto the Premier and to the Cabinet if we have to take different strident actions and urgent actions, which I know that no one's going to like, but maybe what we have to do to prevent deaths, vulnerable people being exposed, hospital system overwhelmed, schools being closed, and long-term care facilities, again, being a large number of difficult outbreak situations and shortage of human health resources among our healthcare workers. And you have to do what you have to do. But at the same time, as Dr. Brown alluded to, when you do these things, there are consequences on the other side, whether it's mental health and that. So these are other ones that you have to weigh out, economic issues, and that is one of the challenges that has to be balanced out in the overall approach. But time is of the essence.
Last question.
Your final question comes from Heather Wright with CTV. Please go ahead.
Hi, I just wanted to get a sense of sort of what's the goal or the end game with COVID here in Ontario. Is it to get to 0 cases or a small handful of cases that would be acceptable? And if that is still the sort of the end game, do you believe that's possible with the current levels of action being taken by the province right now?
Well, yeah, we'd like 0 cases, but it is a global pandemic. And if you're on an island somewhere you can isolate and keep people out, you might get down to that level. As you recall, in the summer, we were feeling pretty good about ourselves. We were down well below 100 for the whole province. And some of those were laboratory false positive cases in there. So we got pretty low. That doesn't mean we stayed down there. Look where we are now. And the second wave has come in, and we have our numbers. If you do it on the extrapolation of testing and different things, I'm not going into details, we're as high as we were in equivalent to the first wave. So even if we go through the first and second wave, will we have subsequent waves? And we have to see, because this is the first time globally everybody's going through second wave. Vaccines are on the doorstep coming. Lots of positive comments about those. We have to see how effective they actually are going to be when we're administering them. So that is still at least into the new year and further on from there. So if you get your level of community immunity, if I can use that, not that it suppresses it down. And of course, we're also watching to see if over time is the virus changing in its effect on morbidity and mortality. And we want to ask our experts to tell us that and to assess that as we go through these different waves impacting our population and how is it affecting our population at writ large, which means our vulnerable, elderly, frail patients as well, and see what's happening with that. So I'd like it down to 0 with a global perspective and how it keeps moving around. I can't see that being for a while. Ideally, our goal is to keep morbidity and mortality down. That was our goal from the get-go. If that was 0 or limited, very small, I think that would be good. If that was totally eliminated, there's no COVID patients in our hospital or dying in any one of our facilities, I think that would be a good objective. But we have to be flexible, we have to be nimble, and we have to keep looking at the data because it's all new ground, it's unprecedented, and we're trying to learn from ourselves, those experts around the world, our experts at our tables, so we can best address it and be nimble and responsive to the changing venue.
Follow up, and this is the last question.
Okay, this is a question for Dr. Brown. You just said before, you said that cases or the number of cases aren't going to change without any action. Do you believe that there should be some form of greater restrictions put in place in some of the hotspots in the province?
If the, as you led off, if the goal is to reduce the number of cases and the goal is to reduce the impact on the health system, then yes.
Thanks, everyone.